Dear students, I am continuing now this ATT anti-tubercular drugs regime, and now this will be third, I mean say consecutive lecture consisting of few slides, and now I am talking about the recent drugs. Three novel drugs currently under clinical development which are active against MDR-TB: linezolid, OPC 67683, and nitroimidazole, and TMC 207 are diaryl quinoline. So, newer anti-tubercular drugs in clinical trials is linezolid, also known as the third line agent. Linezolid is an oxazolidinone used primarily for the treatment of the drug-resistant gram-positive infections, also active against Mycobacterium and tuberculosis. Mechanism of action is disruption of the protein synthesis by binding to 50S bacterial ribosome. Linezolid has nearly 100% oral bioavailability with good penetration into tissues and fluids including CSF. I have already conveyed you that the penetration to the tissues and bioavailability is a plus point, and it also goes the CSF. That means if it is meningitis, I mean say tuberculosis, it will go there also. So adverse reaction may include optic and peripheral neuropathy, pancytopenia, and lactic acidosis. Newer anti-tuberculosis, I am continuing TMC 207 R20 7910 by Andreas et al. In 2005. TMC 207 is a new diaryl quinoline with a novel mechanism of action, inhibition of the mycobacterial ATP synthesis proton pump. TMC 207 is a bactericidal for drug susceptible and MDR against Mycobacterium tuberculosis. Resistance has been reported and is due to point mutation in the gene coding for the ATP synthetase proton pump. A phase 2 randomized controlled clinical trial demonstrated substantial improvement in rates of 2 months culture conversion with improved clearance of the mycobacterial cultures for MDR-TB. Now, this drug is metabolized by hepatic cytochrome CYP3A4. I told you this CYP3A4 has got a tremendous, impact in drug metabolism. Maximum, 60%, 40% drugs are being metabolized by this. So rifampicin lowers TMC 207 levels by 50%. So rifampicin is an inducer. So it reduces the TMC 207 level by 50%, and protease inhibitors also interact significantly with the drug. So protease inhibitors you give in the AIDS and HIV. So this also, inhibitors also are interacting significantly with this drug. The dosage is 400 mg per day for the first 2 weeks, and then 200 mg thrice weekly. Adverse drug reactions are reported to be minimal with nausea and slight prolongation of the QTC interval, and toxicity is not that much, it is minimal. So OPC 67683 and PA824, the prodrugs OPC 67683 and PA824 are novel nitro and dihydroimidazole derivatives. Antimycobacterial activity is due to the inhibition of the mycolic and biosynthesis. Early clinical trials of these compounds are going on, and now changes in RNTCP guidelines has occurred in 2010-2011. Discontinuation of the CAT third regime under RNTCP is the program has now revised its categorization of patients from the earlier 3 categories, CAT 1, CAT 2, and CAT 3 to 2 categories, new and previously treated cases. So these guidelines are being, changing again and again, these RNTPC, and now we have new CAT, new sputum smear positive, new sputum smear negative, new extrapulmonary, new others. Now previously treated was CAT second, smear positive relapse, smear positive failure, smear positive treatment after default, and others. So this you have to go through. Treatment category. category, initial phase and continuation phase. We have new cat1, it is, I mean say 2H3 R3 Z3 E3, 4H3 R3. Previously treated cat3, previously treated 2H3 R3 Z3 and E3 S3, 1H3 R3 Z3 E3. Now it is 5H3 R3 E3. Now what about the chemoprophylaxis? Chemoprophylaxis of TB, prevention of active disease from latent inflammation, and it is indicated by positive Mantoux test. Mantoux test, you know, is an antigen test. We give the antigen in the body, on the arm, and we just I would say make it. It is called as a tuberculin test. Mantoux test is tuberculin test. In this test, purified, you know, protein derivative PPD is injected by intradermal route in normal person, that is in immunocompetent patients. Duration is of 5 mm, and in compromised patients it is 10 mm induction. This induration, it is given on the second, and then we see it is diameter, is considered positive after giving 5 units of the PPD. Subjects require prophylaxis are PPD positive patients but no active disease, negative PPD but in close contact with TB patients. So we have to give these, I mean, say, who are very close, you know, these AIDS patients are susceptible on TB, and those who are serving them, they are very close to them. And immunocompromised patients having leukemia, HIV, taking corticosteroids with positive Mantoux. HIV informed patients exposed to MDR TB cases, they are also, I mean, say, susceptible. We have to have that chemoprophylaxis. Now chemoprophylaxis. Chemoprophylaxis standard drug is INH daily for 6 to 12 months, or INH plus rifampicin daily for 6 months. If INH can be used, rifampicin 4 months, R plus Z 2 months, MDR E plus Z plus, you know, this is a FQ quinolone. So this is the regime for chemoprophylaxis that you have to remember. Chemoprophylaxis, the person is not, I mean, say, having tuberculosis, but who are the relatives who are serving the, I mean, say, these patients, MDR patients are they are on the drugs, they have to take this chemoprophylaxis. The prophylaxis, because the drug is given for prophylaxis. I told you the definition of the drug is given for the prophylaxis, for the treatment, and for the diagnosis. So the development of in the pipeline, there are so many drugs that you have to, why there is in development, we have to add so many drugs, because then new drugs are very much clinically good. So this is the phase 1 clinical trial is going on, and phase 2 clinical trial is going on, and now the phase 3 gatifloxacin and moxifloxacin, it is already done, it is in the, I mean, say, market. Phase 3, phase 1, I told you phase 0 is there in drug development, phase 1, phase 2, phase 3. So naturally these phases are very important in the drug development. So rifaximin, newer non-systemic rifampicin approved for, and rifaximin, this is the newer non-systemic rifampicin approved for, it has been approved for the traveler's diarrhea, hepatic encephalopathy, irritable bowel syndrome, small intestinal bacterial overgrowth, and Clostridium difficile infection. So this is the rifaximin is the newer, I mean, say, analog. So you have to remember this. And now the goal of the new drug component of the global plan to stop TB 2011-2015 to develop and introduce new TB drugs and drug combinations that will result in, now why we do it, we should have a shorter, safer, more effective and accessible treatment regimes. Cure all forms of TB. Compatible with ART like we have, I would say, for the AIDS. Suitable for children. Easily managed in the field. So the field workers, they have to take the drug and it should be easily managed. And then we have achievements expected by 2015. This was a target, now it is again a target because we want to free the India from tuberculosis. And there's a campaign going on in the whole world that the TB should be off. A new 4-month TB treatment regime, 2 new drugs will be approved by regulatory authorities for drug-sensitive TB. At least 1 new drug for the treatment of drug-resistant TB will be introduced into the market. A 9-month regime for the treatment of drug-resistant TB, including at least 1 new drug. Now, achievements expected: fixed dose combinations for first-line drugs, including new drugs, will be available and in use. So we have to have a fixed dose combination, because fixed dose combination, I have already told you, it is the fixed dose which is the rational and it is very, I will say, compatible. It is there is no, I will say, you cannot forget it. You can give it once a day and all the drugs are in the pack. So this is this availability of the FDC is very important. Child-friendly first-line TB formulations will be under development. So now we have anti-leprotic. I have not to go through because there is another person who is going to take this class. Now, thank you very much. I'll be taking, I would say, another class that RNTPC, that will be a video, and I am sure that you will go through that video and you will carry the message that how the eradication of that tuberculosis is achieved and what are the different, I mean, say, fixed dose combinations, what is MDR, what is the combination, what is the first line, what is the second line, and what is the third line, I would say, drugs, what are the drugs which are under development. You have to be very much about these things. And for the drug, I would say, information, I have next lecture that will be taken care of, and you should know why we should have a drug information. What are the, I would say, programs by the help of which we investigate new drugs, and we have to see the new drugs, how they are being developed, what is the literature, pharmacopoeias, new books, and what is the, I would say, evidence-based medicine, what is the rational drug use. These things you have to be clear, and I'm sure the message is that you should be thoroughly going at least 100 drugs, their absorption, their distribution, their metabolism, their excretion, and their pharmacokinetics, their pharmacodynamics, ADRs, and pharmacovigilance. These are all the, I would say, protocols, how you will read the drugs and how you will really go through the drugs and how you make the regime, and what are the different, I would say, drugs which are having the pro-drugs which are having the, I would say, bioavailability, 100% which are having the bioavailability. We don't give those drugs orally or IV. What are the different, I would say, intricacies in them, and this is all because you have to learn, you have to teach, and you have to be good doctors, and you have to be really one of the best. And I'm sure that you will go through these lectures again and again. Thank you very much.